Good morning. I'm Laura Rudberg, MassBio's Director of Events. Thank you for joining us for MassBio's virtual Possible Talks. These are 15-minute talks of inspiring and engaging content in the style of a TED Talk. With us today is Sigal Meilin. She's PhD and Chief Scientific Officer at MDBiosciences. Dr. Meilin will walk through a case study of unique motor and sensor phenomenons in MOG-EAE, Myelin Oligodendrocyte Glycoprotein, MOG. Induced EAE is one of the most common murine models for multiple sclerosis. However, very little is known about the electrophysiology of the motor and sensory systems. By using electrophysiology methods, MDBiosciences has shown the first unique motor and sensory phenomenons that differentiate between mild and later stages of EAE. These significant findings can serve as a basis for new drug screening models for early multiple sclerosis symptoms of pain and motor dysfunction. So we've reserved some time at the end of Sigal's talk for Q&A. And if you look at the bottom of your screen, you'll see a little Q&A tab. You can ask questions throughout. You don't have to wait till the end. And you can upvote any question that you see that would be something you would ask as well, or that you would like to hear the answer of. So I'm going to turn it over to Sigal and let you get started.
Thank you very much, and thank you all for joining us in this morning, this Friday morning. But what we are going to discuss is actually MS and the MS model in mice, which is the MOG-EAE, as Laura just said, is the most commonly used model, is a model for prolonged EAE. There are another two very common models. One is the PLP for remitting relapsing EAE or MS, and the other one is for myelin basic protein induced benign MS. It's a self-limited model and it's run mostly in rats. The MOG and the PLP are run mostly in mice, as we all know. MS is a very serious disease. It affects over 1 million people in the US only, and between 100 to 200 people are diagnosed every week in the US, and they live many years with MS. It's a neurodegenerative disease, it's neuroinflammation disease, and it's autoimmune disease. We will discuss all of it in our slides. But I want you to pay attention to the drawing here of the leaking tube. This is a very nice representation that our neurophysiologist is using every time he speaks about the neuroinflammation damage in MOG-EAE model. And we all remember that if we open the water on one side of the tubes, and then the pool on the other side is filled with water as long as there are no holes along the way. But if there are holes along the way, and there are only few holes along the way, then the pool will be filled more slowly, but also all the surrounding of the tubes will get wet because of the leakage. But if there are many holes, then the tube will not fill with water, and only the surrounding will get wet. And this is a representation of what is happening in an injured spinal cord in MS patients. They are sort of having holes, which is the demyelination, and then the leakage starts and the signals do not transfer. And if we go to the next slide, if we look at the experimental EAE models, then we have an infiltration of immune cells, T cells to start with, and then that leads to production of antibodies, it leads to demyelination, and eventually to paralysis and pain. And that's a question: how do we monitor pain in paralysis animals when the animals actually cannot withdraw from any stimuli with any painful stimuli because they are paralysis? This is how all these projects started. But it took us to really a very interesting scientific journey, finding new waves that were not described before. These are some representative pictures of the histology of the MS, and you can see here CD3, which is the hallmark of T cells, and you can see these dots, brown dots here, which is infiltrating T cells to the spine, and then here is hematoxylin eosin staining, and you see those stars. This is very nice because these are inflammatory areas, and actually the digestive chambers And if you look at the myelin basic protein staining, you will see that it's all white. It's like a hole here, because this area went through demyelination and there are no longer any neurons there. If we go to the next slide, I'm sure everyone in this seminar knows this phenomena of EAE. This is a typical scoring going from 0, which is normal behavior or normal motor function, to 5, which is death. Along the way, we have tail limb here, which is the 1, and then abnormal gait, it's 2, and then severe weakness and more severe weakness of the front limb as well. And you can see that on day 0, after the induction of the MOG, it takes several days before we start to see any changes in the motor dysfunction. And around day 9 or day 10 or 11, we start to see some changes in the motor function of the animal. But on days 15 to 18, right here, 15 to 18, we see this is the peak of the disease, and it stays this way in most of the animals. This is very important to remember, because this is the area where the disease increases, and it stays in a very severe condition unless the animals are treated with any control. Just to show the electrode's location. So if we want to monitor the motor system, we will stimulate the motor cortex, and then this stimulation will go through the tube. You remember the tube from the first slide? In this case, the tube is the spinal cord. It will go through the tube to the gastrocnemius muscle. Sorry. But if we want to record the sensory system, then we need to stimulate in the peripheral. This is the PTN nerve, and it will go all the way to the sensory cortex. Okay, so this is the tubes that we are talking about. It's the spinal cord. Let's see what we get when we stimulate the motor cortex and we record on the gastrocnemius muscle. If you look on the left, this is a recording from a normal animals. Here is the stimulation. It goes up and it goes down. It's a transcranial evoked potential, and it's transcranial because we don't drill a hole in the skull. We just place a needle electrode under the skin above the motor cortex. It's a very nice wave. This wave is composed of 100 stimulus, and it's averaged, of course. I'll show you how a single stimulus looks like. And then this is what happens in a mild EAE, score 1 to 2. What we see here is the desynchronization. It's the leakage of the current from the tube. And then there is the main event, which is more or less the same. And then there are some more subpotentials. These subpotentials, we've seen this picture in one article, but they were not referring to the subpotential at all. It was shown before. Severe EAE, score 3 to 4, you see that there is almost no signal. It's very small, and it takes very long time for the signal to occur. If you look at the statistic representation of all this, and this is exactly what you see. Well, for the amplitude, it's more or less the same between the naive and the mild. It decreased in the score of 3 to 5. If you look at the latency to the main event, then this increases as the disease progresses. Subpotentials we see only in mild EAE, because here there are too many holes. The water do not fill the other side, meaning that the signal will not get from the cortex to the gastrocnemius muscle. And the duration of the total event takes longer, and that makes sense. And this is what we expect to see in EAE mice. But what is happening to the sensory evoked potential? This is a representative of a recording from a one stimuli, and this is a sum of 100 stimuli, and this is new. This was not shown before. We identified what we call the P25 because it takes about 25 milliseconds to occur. And this wave is very nice and has a very, very good shape that we can refer to. In the naive animals, there is no difference between the left and the right. What is happening in EAE MOG animals? So this is the naive, and look how high this signal goes, it's almost triple and sometimes even more. So there is a very, very high sensitivity in those animals, in score between 1 to 2. This is not a severe disease, it's a mild disease. But in the mild disease, what we see is a very high an increase of the SEP, of the transcranial SEP, which means that the animals becomes very, very sensitive. And this is the statistical representation of that. So on the y-axis is the microvolts, and you would see that in the naive animals, it's about 30 to 50 microvolts. This is a normal amplitude. But then in a mild disease, score of 1 and 2, it's double or triple, and look how high it can get. Here there is one animal with even 300 microvolt amplitude. In a severe EAE, it goes below the baseline, meaning that here the spinal cord are really injured and really damaged, and the signals do not go through. So if we look at the changes of the P25 as the disease progressed a long time, and remember, the disease starts about day 10, and here is the naive animals, you see it about 50 microvolt, and then on day 10, with mild disease, it's only starting. We have very difficulties even identify the motor dysfunction in this day. It already at 100, that's the average, but it goes between even up to 200 and more. On day 20, you remember the first slide when I show you the clinical score, and I said that between day 15 and day 20, this is the peak of the disease. On day 20, there is a decrease actually of the amplitude, and then on day 30 and 40, when the disease becomes very severe, but there is no difference in the clinical score. The clinical score is pretty much stable on day 20, but we can identify further damage using the P25 reporting. And this is just to mention here that on day 10, there are very little animals that show any kind of disease sign. And any of you that are working with MOG-EAE knows that in some cases, we do have animals that we induce them with MOG, but they do not develop a disease. It's about 80%, 85% of the animals that are dosed with MOG develop the disease and the motor dysfunction that we're all familiar with. But about 10, 12% of the animals do not show any signs of motor dysfunction. We asked ourselves if this is also the case in P25. And this is the answer. And the answer is, it is not the case for P25. Because even those animals with score of 0 that do not develop motor dysfunction do show an increase in P25 amplitude, which means that they are damaged. They are not naive animals. And it might be that with additional boost of MOG or additional boost of anything that would push the disease a little bit further, we will see some also motor dysfunction in those animals. That means that the electrophysiology of the sensory system is actually a good predictor of what is going to happen in the motor system. So since we are working with the sensory system, we were wondering whether we can affect the SEP, not by damaging the spinal cord or by creating these holes in the spinal cord using demyelination model, but actually by using an analgesic agent to just block the transmission of the sensory system. And the answer is yes, we have used morphine, which is a blocker of the sensory system in a naive animals, and you see the massive decrease of the P25 wave here. So this system can also be used to identify block of the sensory system. So what are the significant findings in the EAE using electrophysiology? So the first one is the transcranial motor evoked potential. we expect and to see changes in the motor dysfunction, because we also in the motor electrophysiology. Sorry about that, because we also see motor dysfunction. So that's reflected in the electrophysiology monitoring of the motor system. However, the electrophysiology of the motor system also could identify different stages in the progression of the disease between, for example, day 20 and day 30, which we cannot distinguish using only the clinical score. And using a transprandial SEP monitoring, we have identified for the first time the P25 wave in a MOG-induced EAE animals and how it changes as the disease progresses, but also how it is responsive to different analgesic. And we have diagnostic methods for early EAE signs, which brings always the question, what is a prophylactic versus therapeutic treatment in an EAE model? So thank you very much for listening. And now I'll be happy to answer any questions.
Hi, sorry, Sigal, my mouse was being difficult. Let me turn back on your video, and we do have a couple of questions to ask. There we go. Your video should, if you can just turn your video back on so we can see you, it'd be perfect. We got multiple questions here. So the first question, and thank you, I do not know anything on this topic, and I feel like I'm a little bit more educated now, tiny small amount.
Thank you.
How can we confirm that P25 is correlated with pain?
So yeah, it's a very good question, because what we are monitoring is the sensory system, and we cannot be sure that this is pain. So what we did while stimulating the animals, even though they're under anesthesia, they tweet a little bit. So we quarter their vocalization, and we correlate their vocalization with the amplitude of the P25, and there was a one-to-one correlation. The higher the amplitude was, the more frequency we have, the higher frequencies we had on the vocalization recording. So we're pretty much sure that we do monitor pain.
Yeah. Have you looked at P25 in peripheral nerve damage, such as in peripheral neuropathy models?
Yes.
Neuropathy models.
Yeah. So yeah, thanks for the question. So once we identify this wave, we obviously were triggered to work with this system on every model that we have. And since we are working a lot with neuropathic model, whether it is pain, peripheral neuropathy, or spinal cord injury, then we applied these methods in all our models. And what we do see is that in diabetic, for example, diabetic peripheral neuropathy, such as just either by high-fat diet in mice, or in rats, we do see changes in the sensory system. In rats, we have additional methods of monitoring it, which I won't go too much into it, but we do see changes in P25 in other models as well. Yes.
And so you've mentioned rats and mice, but do you perform electrophysiology in other species?
Yes, so we perform electrophysiology in mice, rats, and in pigs. We also work with large animals, because the pig innervation and the peripheral innervation in the pigs is more resembling the human situation. So we do monitor also the pigs, and of course, once the animals is larger, it allows us to do more monitoring, whether it is from the sciatic notch and then record spontaneous firing from the sciatic notch in rats, or from the spine.
Well, that's the questions we have so far. Anybody on the call who would like to throw another question up there? We have a few more minutes if there's anything else. Oh, wait, there's something in the chat. Let's see. Oh, people are asking questions in the chat. How does this diagnostic translate to a human? Okay, so we have mice, rats, pigs. Now we're just going to jump right to humans.
Yeah. So yeah, we think yes. I mean, all the methods that we are using are also used in human. And we know that in EAE, for example, the patients sometimes will come with some issues in seeing. They don't see very well, or they describe some kind of blur, which normally reflects starting of demyelination of the visual system. So the answer is absolutely yes. We do think that it is translated to human.
And one more question that was in the chat. Please explain a bit more about differentiating the prophylactic versus therapeutic effects.
Okay, so we saw that the P25 is actually responds and gets higher or more strong before we ever see the motor dysfunction. Normally, what we face is that people will start treating the animals when they see the first sign of disease. And their identification of first sign of the disease is that when they see the motor dysfunction in the clinical score. But we know now that the first clinical signs actually happens a lot sooner in the sensory system. So prophylactic, it's easy. It's just dosing the compound before the stimulation of the MOG, or let's say with the stimulation of the MOG. But using a therapeutic approach, that's more difficult, because we know now that the therapeutic approach might start even on day 8 or on day 9 or on day 10, when actually the sensory system is affected and not the motor system is affected. So there are different ways of looking at the prophylactic approach, the therapeutic approach.
Yeah. Oh, more questions coming in. Have you used these methods in other EAE models?
Not yet. We are aiming to do so, but we haven't used it in other EAE models yet. It would be interesting to do that in the remitting relapsing model, for example.
I have a friend who has that, so I would be interested to hear about that. Have you tested any of the approved MS drugs in your EAE mice? So existing
Not
drugs.
yet. Yeah, very good question. Not yet. We do use, Copaxone, fingolimod, and even dexamethasone in those models. They all serve as positive control in our models, but we haven't looked at the effect of those treatment on the motor and sensory system. It would be very interesting to do that. It's down the line in our research. Yes, thank you.
That was a very logical question. Let's see, any more coming in? That was all in the chat. Nope, I think that's all the questions, unless anyone has any other ones. Sigal, do you have any closing statements that you wanted to make, or any final findings you wanted to share?
No, just thank you all for listening, and we hope to publish those results really soon. And then the coming research will be shared, of course.
Well, it's funny because as you said that, somebody typed, is there a paper that distills this research?
Yeah, so yeah, we're working on this paper. It's there is a lot more data into that research. I just gave the highlights, and yes, yeah, we found a lot of changes in the electrophysiology of the mouse that are very, very interesting. So yeah, we hope to be able to publish by the end of the year. We're just putting everything together now. Yeah.
Awesome. Mark, I see your name there. I will share your contact with the team at MDBiosciences, so when they have that paper, they can share it.
Yeah.
Yep. Well,
we do have a poster that we can share.
Oh, yeah, if you want to share that, for sure. We'll make a connection. That'd be great. So with that, guys, that's our Friday Possible Talk. Thank you, Sigal, for spending some time with us this morning. I hope everybody has a great weekend. It's Father's Day. Call your dad. And everybody have a wonderful weekend. Thanks for coming.
Thank you very much. Thank you all.